Good afternoon, everybody. These are the true believers. Afternoon sessions on the last day. I appreciate it. All right. So hi, everyone. I'm Courtney. I'm from the Ohio State. I need to fix that on this slide. But I'm going to talk to you today about some female hernia anatomy and why it's different than men. So I have nothing to disclose. I think it's important to acknowledge that men and women are different in many important ways. I think. That is actually how I tell stories, by the way, on the bottom. So I think it's really important as we kind of talk about that, men and women are equal, but they are also very different. So let's talk about what structurally what that means. So we're gonna start with the bones of it all. If you look at male and female pelvises, males over on the left here. Males have much thicker bones. They are also taller, and they tend to form sharper angles, which means that the ligaments that they attach to, Coopers, all those sorts of things, also come in at sharper angles. Women, on the other hand, have wider pelvic openings. They have much shorter inlets, and they overall just kind of broader. And the other thing is that female pelvises are often kind of a moving target. They may have to remodel multiple times over a woman's life as she goes through childbirth and that sort of thing. So they're a much less fixed structure. And then you overlay muscle onto it. This is, I'm sure, yeah, that's my patient, all for sure, both of them. And so females proportionally have broader rectus muscles than males. I know it's actually kind of a little counterintuitive. We all kind of think of women as being like tiny little things, but proportionally they actually have broader rectus muscles. And again, because of the work that our pelvises do, they have better developed muscles in the lower part of the abdomen. So they have more developed abdominis and transversalis fascia. The internal rings tend to be smaller for reasons that I'll get to in a second. So this means they have overall better protection against femoral and indirect hernias, kind of, but then you'll see that, proportionally they actually end up having more femoral hernias than men. But in theory, they should have better protection down there. So of course we got to talk about, the actual bits. So I'm really bad at embryology. But this is kind of what I remember. Like the testicles start up in your belly somewhere, and then they sort of like meander down this direction somewhere. And then by the 9th month, they end up down here. And then, as we all probably remember very, very accurately, the process behind is supposed to close up after that. But that often does not happen. And so that is why men are at much higher risk of hernias, and something we need to really keep in mind. So in conclusion, all you men out there have less robust muscular tissue. You have more acute angles that are more likely to cause problems, and you have inherent weaknesses of your pelvic floor from the very beginning, which means you guys get more hernias, and I feel so sad for you. So what does that mean in practice? Well, obviously the lifetime risk of male hernias is about, almost as high as 50% for all comers. And they tend to all be true inguinal hernias, so either direct or indirect hernias, with a very small proportion of femoral hernias. Now, females have much, much lower incidence of hernias, we think. We'll kind of get into how we may not actually know. But they're distributed very differently. They are still mostly indirect. This is, for med students in the audience, this is a favorite pimping question, that even though women are more likely to get femoral hernias than men, they're still largely indirect hernias. And so I think this distribution is really important. We'll kind of get into how this sort of makes us underdiagnose hernias in females, because we don't really think of them. The other thing, and again, as Annie will talk about, is we don't really have a lot of data on hernias in women. We just don't really know a lot about it because we don't see it that often. And this distribution is also important. It means that women are at different risks of hernia presentation and hernia emergencies. So let's talk a little bit about presentation. And so groin pain in females confuses people. It confuses me all the time, because you can have a lot of different sources of pelvic pain that are all pretty reasonable, and they can all be happening at the same time. I think people, like we talk about, like a 3 to 6% lifetime incidence of hernias, that's pretty low. And so we tend to have a very low suspicion. Kind of pair that with, because of the anatomy, hernias tend to be smaller in women, and they don't get the kind of stereotypical bulge all the time. So they'll kind of have vaguer complaints that are a little bit harder to parse out. And then again, because I think of all of these things, because of the low suspicion, the other possible sources of pain, and because they're harder to detect on exam, plus the fact that they have a slightly higher incidence of femoral hernias, they're more likely to present emergently, either because of the femoral anatomy or just because nobody thought of it until it was actually a major problem. So surgical considerations, again, I'm setting Annie up for her talk right now. We don't really know. We do our best, but this is what I sort of think about. Whenever you operate on a hernia in a female, you have to have a high suspicion for a femoral hernia. I do most of my hernias robotically anyway to get a really good view of the myopectineal orifice. If you do yours open, that's fine, but just always remember to sweep down and check the femoral space. You really want to size your mesh appropriately. And this is kind of the error I see when I have trainees in my OR, because they sort of think that women are just tiny little girls, But remember, their pelvises are actually broader, And so you actually want to make sure that you're really dissecting out those medial parts of the pelvis, because it is a much broader inlet. And remember, you have to cover it kind of thinking, especially in younger women or women who may still have children and go through other sort of physiologic changes. You sort of have to cover the whole area because it's a moving target. And the other thing is, when you're there, don't get tunnel vision. Remember that women do have a lot of pelvic pathology. And so, don't go in there because you have an ultrasound of a tiny hernia and miss that there's, endometriosis deposits all over the place. You have to sort of always be cognizant that there could be something else going on. And I know we have a whole talk on this, so I'm not going to put it too much, but I'm going to put my queer hat on for just a minute. So we all know that gender is getting a little bit more complicated in society. So, we don't always know for sure the biologic gender of the person sitting in front of us, So take time to kind of establish that. If it's not clear, or if you feel like you need to kind of figure out, it's okay to ask. Again, I think this is going to be in the talk later. Be respectful about it. Explain why you need to know. And kind of explain all these things. We know we need to know your biologic gender because XYZ thing. That's actually very important. And also, I would say, if you don't need to ask, then don't ask. If you have a CT scan that tells you what the anatomy is, then you don't actually need to ask the question. But then from then on, really treat them just the same as a cisgender person. Remember, anyone with a uterus, no matter what clothes they're wearing, might be planning on having children, even if they are wearing a suit and a tie. So you have to sort of go through the same algorithm as you would for a cisgender person. But you also have to ask other relevant questions. And again, I don't want to step on the toes of people coming later. But, again, remember, people may be planning to have children. They may be planning to have a hysterectomy. You sort of have to tailor your history for the person sitting in front of you. And this will feel incredibly weird. It does, even for, you're going to trip over pronouns. You're going to trip over a lot of vocabularies. This kind of gets socialized more and more. I am queer, and I still kind of struggle with this. And it's okay that may feel a little bit weird at first. Don't let that stop you from trying to take important parts of the history. That is all I have. I look forward to the discussion.